Hello, everyone, and thank you so much for joining today's educational webinar with Cancer Support Community Los Angeles. My name is Kathy Riley. I'm the Associate Director of Programs with CSCLA. I'm honored to welcome you to this week's webinar titled Health Disparities in Diabetes and Cancer, Challenges and Opportunities. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is the premier nonprofit organization providing vital social, emotional, and educational support to families facing cancer, including patients and caregivers and loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services, please visit our website at cancersupportla.org. And before I introduce today's wonderful speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature that you'll find at the bottom of the Zoom window at any time. So please feel free to add those throughout the presentation. Questions will be answered at the end of the presentation. We may not get to all of your questions, but we'll get to as many as possible. Dr. Greisha Ortiz is a postdoctoral fellow and trainee under the National Cancer Institute Cancer Metabolism Training Program in the Division of Biomarkers of Early Detection and Prevention at City of Hope National Medical Center. Her research focuses on exploring and targeting malignant pathways leading to prostate cancer and understanding the importance of racial and ethnic differences in clinical outcomes. Specifically, her research and project focuses on targeting IGF axis modulators in the context of prostate cancer and health disparities, especially among those in the Latino population. She has served as a researcher, an instructor, a mentor, and her goal is to use her scientific knowledge to identify gaps in care delivery to vulnerable populations and communities, and to improve the outcomes of their treatments. In addition, she is using her cancer research experience to engage with communities and train the next generation of cancer scientists. Dr. Ortiz, if you want to turn your camera on and unmute, it is my pleasure. Welcome.
Thank you for having me.
Yeah, I will let you take it from here, and I'll see you at the end for questions. But thank you so much again for joining us today.
Thank you for having me again. I'm very excited to be here. It's my first time presenting to this community, so I hope it's not going to be the last one. Please let me know if you can see my screen.
Yes, it looks great.
Perfect. Okay, so let's talk about two of the things that for me, I'm very passionate about. Health disparities in diabetes and cancer is part of my research, what I'm doing at City of Hope. So I would like to talk about especially how these two aspects, two diseases can interplay and how they can actually lead us to more challenges in the field, but at the same time, opportunities for our communities. With that, I would like to present the context of the presentation. So first, we'll have some introduction section in which we can basically discuss concepts so we can all understand throughout the presentations. We're going to talk about the epidemiology of diabetes right now. We're going to talk also about the triple threat. What is that? Also, we're going to explore the disparities in diabetes and cancer risk. Also, for me, it's very important to also talk about the mechanisms that scientifically has been proven to link the three of them, obesity, diabetes, and cancer. Also, how we can break the link between the three of them. And also pose some questions to advance the field. And at the end, we're going to have some conclusions, and also we're going to be able to answer some questions for you. So first of all, we need to define what is obesity. So according to the World Health Organization, obesity is defined as an abnormal or excessive fat accumulation that presents a risk to health. And for example, currently body mass index is like a tool that is being used to consider you being underweight, normal, overweight, or obese, or extreme obese. If you are 25, if your BMI is 25, you're considered overweight. And over 30, you're considered obese. And this issue for sure has grown to epidemic proportions, with over 4 million people dying each year as a result of being overweight or obese. And with that, we also would like to define what is diabetes. Diabetes is a disease that occurs when your blood glucose, and in this case is called the blood sugar, when that is too high in your bloodstream. And having too much glucose in your blood can cause many health problems. And among these problems, we have heart disease, which is currently the main cause of death among every human being in the world. Also, it damages the nerves. With that, also, you can have eye problems and kidney disease. And how your body operates, right? And how your body normally can control blood sugar levels. So basically, when you eat something, that food is converted into glucose, which again is blood in sugar. So as blood sugar levels rise, the pancreas, which is this organ right here, makes insulin. And insulin is the one that when it carries the glucose in the blood, and it helps you to bring that glucose into the cells. So basically, the insulin, when it's secreted from the pancreas, is the key that opens the cells, so the cells can then absorb glucose from the blood. And why that's helpful? Because once your cells receive glucose, that glucose is break down as a form of energy. So without that, your body basically can function, your brain can function as well. So it's not needed in the blood, it's needed inside the cells. So the issue with diabetics is that the efficacy of insulin is very much diminished or decreased, either because there are two types. Type 1 diabetics is when the pancreas doesn't secrete enough quantity of insulin. And we have also type 2 diabetics, in which the body cells are less responsive to include or open the access to that insulin, to the glucose to get into the cells. And type 2 diabetes is the most common one right now. And also there's epidemiology aspect to this, in which there's an estimate of 30.3 million people in the US. And with that, that's about 9% of the population has diabetes right now in the United States. It's also known that about 1 in 4 people with diabetes don't know they have the disease. Also, an estimated of 84.1 million Americans aged 18 years or older are pre-diabetic right now. And very importantly for communities, the prevalence of diabetes is higher among the Hispanic origin, with 14.7% and non-Hispanic Black 16.4%, as compared with other racial and ethnic groups. Now, how we can link obesity and diabetes. So it's projected that by the year 2030, 1 in 2 adults in the US will have obesity, and that's a high number, that's 50%. And 1 in 7 will have diabetes. And obesity is a strong risk factor for the development of diabetes, and it's known that half of the people that are diagnosed with diabetes have obesity as well. And also increases your risk for developing type 2 diabetes, especially. And if we think about the multiple racial and ethnic subgroups that also experience this, and we break this down, We know that by sex, females are more prone to have or being more obese than males. And also, when we talk about race and ethnic groups, also non-Hispanic Bloods are more prone to be severe or have severe obesity. And after that, we also have the Hispanic group with 27% of them having high moderate obesity. And also another important aspect of health disparity is how how accessible are these resources such as health coverage. And also the annual household income can also affect because you have less access to good quality food. And with that, we can start talking about cancer. So we can start linking the three of them. So cancer is basically one of a large number of diseases that are characterized by the development of abnormal cells. So we have, for example, in our skin here, we have normal cells. And normal cells, they should die normally. Like, for example, our skin have millions of cells, and those millions of cells, they die every day, and that's normal. The issue is when those cells don't want to die. So that abnormality makes them to divide without control. And some of these cells had the ability to infiltrate and destroy normal body tissue. And again, cancer often has the ability to invade other areas in your body. And cancer is currently the second leading cause of death in the world. And as I mentioned before, the first cause of death in the world is heart diseases. So how we can link obesity and diabetes as a cancer risk factor? So in 2016, the International Agency for Research on Cancer and the World Cancer Research Fund reported specifically that obesity was not convincingly linked with the development of 13 different cancers. And we have a picture here with all those different cancers. We have meningioma, which is cancer in the tissue covering the brain and spinal cord. We have esophagus, which is known as adenocarcinoma. We have multiple myeloma, which is cancer of the blood cells. We have also the liver. We have cancer in the gallbladder. We have cancer in the pancreas. We have cancer in the thyroid. We have also breast cancer, which develop especially at postmenopausal. We have gastricardia in the upper stomach. We have colon and rectum. We have kidney, renal cancer cell disease. We have ovaries and we have uterus. And you will see that in some of these names, there's an asterisk. That means that those cancers have also been established as a relationship with diabetes, other than obesity as well. So very recently that has been established. In accordance to these three important factors, is known that people also with type 2 diabetes are twice as likely to develop liver and pancreatic cancer. They are also higher, they're in a higher than normal risk of developing a colon, bladder, and breast cancer. It's also known that diabetic women with breast cancer have a higher mortality rate than women with breast cancer by itself. And oddly, and very interesting, diabetic men run a lower risk of developing prostate cancer. But this has been studied more in depth, and there are some different ethnic and racial disparities that we have to discuss, and they are still in the process of being studied. So we have this balance between cancer and diabetes, and these risks have for sure prompted some researchers, such as myself, to consider the value of cancer screening for some people with diabetes. If we can screen them before, maybe we can prevent them to having the higher risk of succumbing into these diseases. So now we talk about the triple threat of obesity and diabetes and cancer risk. And that is what in the field has been known, these three components. We have cancer, we have diabetes, and we have obesity, the triple threat. So after diagnosis of diabetes, it's known that the risk of cancer is elevated for over 20 years lifespan. Prediabetes is also associated with an increase of cancer risk. And very interestingly, studies have reported that there's a genetic predisposition to diabetes, and insulin resistance is also associated with cancer risk, including among that genetic factors, the fact that families carry these genes and these mutations down the line. And also very interestingly, after cigarette smoking, obesity is the second strongest modifiable risk factor for cancer, meaning that, for example, if you quit smoking, the risk for you to develop cancer down the line decreases. Same with obesity. We are able to revert obesity, then that can lead us, right, to decrease that risk for that cancer risk as well. And one example that I always like to bring to the table is the fact that there's for sure some disparities associated in diabetes and cancer risk. And for example, in cancer, these two type of cancer, prostate in men and cervical cancer in women, right now are two of the cancers that have been, there's more evidence for a health disparity association. Why? We see here that, for example, for prostate cancer, the mortality disparity for the African Americans group, Black and non-Hispanic, especially have decreased, increase in mortality risk associated with the disease. Also for cervical cancer, it is known that also Hispanic have higher probability to get the disease than other groups, as for example. Also, there is a racial and ethnic minority subgroups that experience a disproportionate burden of cancers. Another important aspect that I would like to also discuss is for sure the fact that we have, and we discussed this before, the body mass index. So we have, for example, that measuring health risk by body mass index might be inaccurate across racial population. And this is something that it has been shown to be very problematic, and there's a lot of discrepancies in this sense. Why? Because BMI not necessarily quantify excess adiposity and metabolic abnormalities consistently. And again, at the same BMI, those assigned, for example, female at birth tend to have more body fat than those assigned male at birth. Also, it's known that older people have more BMI or higher BMI than younger people. Also, athletes are known to have less BMI, or the BMI is less than non-athletes. Also, people of Asian descent tend to have more body fat than white people at the same BMI. And also among Black and Hispanic women, for example, abdominal obesity, so not only the BMI, and abdominal obesity is basically the waist circumference or waist to hip ratio. It's a stronger predictor of breast cancer risk rather than just the general adiposity that is measured by BMI. And this is something, an aspect that is very important to tackle. This is something that I always like to talk about because we are all not made the same way, right? So these regulations have to consistently be seen through a scope of access and diversity in our population. Also, in addition to that, in terms of the disparities that we are also talking about, is the fact that there are different epidemiology studies that have provided mechanistic insights about how obesity and diabetes, for example, can impact tumor characteristics and how these tumor characteristics can vary by racial and different ethnic groups. And again, for example, if we have a Black woman, we know they are more likely than white women to be diagnosed with estrogen receptor negative and triple negative breast cancer, which both of them are more biologically aggressive and have poorer prognosis. So understanding these epidemiological issues down the line can help us make better decisions at the end for these groups. And one of the questions that we had is, what is the mechanisms that scientifically prove the link between obesity, diabetes, and cancer? And that's something that personally I'm very interested in. So currently, the biological mechanisms through which obesity and diabetes promote tumorigenesis or formation of tumors still remains incompletely understood, but it is known that it's very likely multifactorial. So different factors can influence the mechanisms linking this triple threat. In preclinical models of breast cancer, for example, in which we have more evidence, it's known that by suppressing just the weight gain and accumulation of lipid in adipose depots via dietary energy restriction or increasing in physical activity, had been able to reduce tumor incidence of mTOR. And I would like to explain that later. Which will, at the end, reduce rates of cell proliferation and vascularization, an increase of apoptosis. So all of that means that, for example, there are different growth factors in our cells that when they are triggered, there is a cascade of signaling. And this cascade of signaling can promote cancer cells to change their formality, and so then can become malignant, to increase cell growth, to increase migration, invasion, to increase apoptosis, and increase angiogenesis. So in these models, what they have done is that basically just by decreasing the weight and increasing physical activities, they were able to see a reduction of this specific effector right here called mTOR. So if you basically eliminate mTOR, you are decreasing growth, you are decreasing migration and invasion, you are decreasing apoptosis, and you are decreasing angiogenesis or formation, right, vascularization of these tumors. And why this is important? Because with that, we can link what we know about population sciences and population studies and using mechanistic interventions to lower the risk for cancer, which is very, very interesting. But again, there's still a lot of research being done in this area. And especially in my lab, we're very interested in one of these growth factors to see if we can also diminish the cancer risk, but in prostate cancer. So adding a little bit more information in that sense. So again, how do we break, right, the link between obesity and diabetes with cancer? And one thing that is very simple and might sound logical, but there's evidence, actual scientific evidence, is by changing your lifestyle. So just by changing lifestyle, you can modify and also decrease the risk for cancer. And how so? So in one study called the Diabetes Prevention Program, basically what they did, they established that lifestyle modification by increasing exercise, decreasing weight, increasing the ingestion of food that are better for your health. And they compare that lifestyle modification with the ingestion by itself of metformin, which is a known oral anti-diabetes medication. And they were able to see a reduction of progressions from pre-diabetic to diabetes by 58% just by changing lifestyle modification versus 31% using metformin by itself. Another very cool trial is called the Look Ahead trial, in which they were able to address for 11 years the effect of lifestyle modifications on cardiovascular risk. And remember, cardiovascular risk and diseases is the main a factor for mortality in the whole world. They show a 16% reduction in obesity-related cancer, meaning that that was basically the first evidence that the effects of obesity and on cancer risk might be reversible again. Another way that we know that we can use to break the link between obesity and diabetes with cancer is through metabolic surgeries. And those are procedures that aim to surgically help with weight loss or treat metabolic diseases. We have two types. We have the sleeve gastrectomy, and also we have the gastric bypass, which are very well known. And it has been shown in studies that just by performing this type of surgery, yielding 25% weight loss at 10 years and induce a diabetes remission with low operative morbidity, mortality by 5% and mortality by 0.2%. And that's a very interesting and great number. Also, for patients who undergo this type of surgery, they're currently at a lower risk of developing cancer in comparison with the patient that doesn't go under this type of surgeries as well. In addition, it has been shown that also meta-analysis of more than 13 observational studies have reported that surgery was associated with a 44% lower risk of invasive cancer. And that's amazing. Also, we have one question from the audience, and that question was related to the impact of my diabetic treatment in cancer. So right now, there are several studies, especially in the area of breast cancer, in which they have been trying to use metformin to see correlations, right, with a decreasing how metformin can help obviously decrease the levels of glucose, can inhibit insulin that is delivered from the pancreas, to at the same time inhibit tumor burden. And even though many of these studies have examined the anti-cancer effects of diabetic medication, the use of observational designs have been used primarily, but again, they have been limited by the various type of biases, including BMI, as we discussed previously, and also the non-inclusion, right, of participants that are from diverse ethnic racial groups that we know are more impacted by these diseases specifically. And right now, I'm part of how we can advance, right, the field in terms of tackling this triple threat. So we felt that first, collaboration is key in order to tackle three different aspects and these three very important diseases that we need to tackle. We need to use multifactorial, but at the same time, we need different fields coming together at one. And with that, also collaboration with community partners, collaboration with community leaders, collaboration with physicians, with researchers, so that way we can also open, right, the access of this type of investigations, and also screening. We need to increase also screening throughout all communities as well. Another important questions that we need to address, right, as we move on to advance the field is which type of measurements of obesity and diabetes status are the best to prognosticate cancer risk when and for whom. So in this sense, we have other than, for example, BMI right now, we can use optical imaging technology to quantify body composition, and that can help us to also include in these measurements BMI, also the waist to hip ratio, and that can help us determine the risk or the prognosis of these type of patients and the risk, establish the risk for them to down the line being a high risk of acquiring different type of cancers. Also, right now, I'm very excited because technology can help us in so many ways. And with that, we can continuously monitor glucose with these devices that are being available right now, and accelerometry embedded into digital devices such as our Apple Watches, Fitbits, etc. So with that, independently, we can also perform these measurements throughout the whole population in general. Another important aspect is how and when we can start tackling, right, these issues since we are kids, since we are adolescents, for example. And across the field, it has been talked about the importance of measures across the lifespan that have been really, really appreciated. Why? Because it's predicted that 57% of children today will be obese at the age of 35 years old. And that's due to obviously a decrease in physical activity and not eating the right way or accessing to right food. It's also known that children with obesity have similar cardiometabolic risk factors profiles as adults, including prediabetes. And adolescent obesity is right now considered a midlife predictor for cancer risk down the line. Also, a very important aspect is how we do this in a way that we can bring more diversity, right, to our studies. So currently, there's insufficiently racially and ethnically diversified inclusion to identify clinical effects of different drugs, for example, in different groups. So one thing that we need to do for sure is to enroll in study participants from diverse backgrounds in sufficient numbers. We have not enough participants that are diverse in a scale, right, that in this case are statistically significant, that will enable the identification of distinct obesity and diabetes phenotypes. Also, we feel that it's very important to determine clues to social determinants of disparities, because that can lead us to more mechanisms of action. And also, we are going to be able to identify population subgroups that are more likely, right, to benefit from these interventions. And also, these interventions cannot be one size fit all. These interventions should be tailored to include culturally relevant design that approaches their relevance, appeal, and also how to make them more effective down the line. So with that, we know that obesity and diabetes are complex diseases that are independently and jointly risk factor of cancer. And the collective burden of obesity, diabetes, and cancer right now, as I mentioned before, represent one of the largest public health challenges of the century. And by targeting this triple threat, we know that we can gain better health and get and have better wellness. And in the scientific world, in the public community and social community as well as the medical groups, we know that tackling the three of them will be considered the grand slam, because once you tackle the three of them, you're going to be decreasing the risk not for only cancer, obesity, type 2 diabetes, but for heart disease, for kidney issues. So we are not going to be only tackling these three, but many other issues that are related with each one of them. And with that, I would like to thank you for your attention, my lab members, my postdoctoral training office. Also, again, thank you, the cancer community in Los Angeles, for the invitation. It has been very amazing. And thank you, everyone, for providing great questions. This is different ways you guys can connect with me after we are finished with the webinar. So please do so if you have any more questions. And with that, I have here some questions that we had from the audience before. One thing is that for sure, most of these questions that are related to how to access to health and different services. Right now, I'm not a provider, so I cannot tell you exactly what to do. But in general, these questions were amazing. Thank you for providing them. One of the questions that I consider was very important is first, what is the impact of my diabetes on my treatment of cancer. And right now, obviously, that will depend on the type of treatment you're given. Also, we received another question, and that one was related in how to locate clinicians sensitive to health disparities, what can be done to bridge the health disparities in the Black, Indigenous, and people of color BIPOC communities. Again, I feel community partners are super important in this sense. I feel that once you identify that community partner that can help you, that can be also more relevant, right? And you can use more information that are more relevant for the type of community you belong. Another great question, two questions that we actually had that I feel are very related to each other. Is the first one, my mom was diagnosed with cancer and she's diabetic, she's Latina. How can I advocate for the best treatment for her? And the other one, which I can also relate, how do I advocate for myself without coming across too angry? For this question, I feel that bringing information regarding her disease will be very important, because that way you will know what questions to ask specifically, and bring a list of questions. Most of the physicians I work for and I work with, one of the issues that we always talk about is we need to provide obviously information to the patient. Well, what information have you been looking, right? So I feel that if you bring correct information and you provide specific questions for your issues, maybe you can get more, right, about those one-on-one encounters. What are the major challenges I see in health access? I will say insurance coverage, and that has been studied at so many levels. We know that access to a good insurance coverage, that's one of the main challenges in health access. Another important question was, can carbs really be substituted with fat? And that one was also very interesting, and I'm not a nutritionist, but what I can say for sure is that they can be swapped as long as, neither is taken too low. I feel that, and we know based on scientific studies that restrictive diets are also not the best. I feel the best thing is to balance everything out. Another great question that we had is, how do we best reach people who are scared, resistant to seek treatment due to their body weight or socioeconomic status? I feel the root of everything is understanding what is their issue. Most of these people have issues related to psychological stresses and many other issues that we can spend a whole afternoon talking about them. But I feel that one way to address that is understanding what is the root of their issues. And I don't know if we have more questions.
So much for what a rich and meaningful presentation. We've received a few questions in the Q&A, and I would invite anybody who, we've got a few more minutes left, so if you have a pressing question, something in addition to the wonderful information presented, please feel free to go ahead and type it into the Q&A feature, and we'll try to get to it before we conclude today. But one of the questions we received is, if someone has a diagnosis of pancreatic cancer and also type 2 diabetes and is seeing an oncologist for the first time, what recommendations do you have for questions that they might ask, to ensure they receive the best possible treatment and most effective care possible?
I feel that one of the most important pieces of information you can also provide to the oncologist for that appointment is to bring like a specific list of treatments you're given in terms of medications you're taking, because down the line, that will be the most important thing to be considered as a physician in terms of what treatments are going to be given for the cancer. We know that there are different pharmacological aspects to how different drugs interact with each other. And for sure, your oncologist will know which ones are the best. So I feel that providing also the physician with all the information you can, being honest also with your lifestyle, your access to health as well is very important. So I feel being honest first, bringing all the treatments you are being given, and having that conversation one-on-one, that will be very, very important to open the door for the optimal treatments for specifically the pancreatic cancer. So I feel that will be my suggestion. Bring all the information for the treatments and being honest also. And bring also specific questions. If you have questions that for you are very important in terms of how do you access treatments. If you are afraid of something, right, regarding to the treatment, I feel that will be very, very great. And then you can receive the best optimal, information and also decision in accordance to the treatment that are being given.
Wonderful. Thank you for that. An additional question that has come in is, as a type 2 diabetic who has a bariatric sleeve, this question is wondering, and also a breast cancer, has received radiation and chemotherapy for breast cancer. What recommendations do you have now moving forward? How does someone enjoy a healthier future?
I will say one of the main aspects, and this is basically based on a lot of scientific literature, is lifestyle modification. I feel living our life the best way, it's also taking care of our bodies, right? So you had two big procedures being done, in your body. So I feel wellness encompasses everything, right? Not only treatments, not only surgeries. It's an issue of how I can modify my lifestyle by either doing some changes on your diet, increasing exercises. Other important aspect is to be connected, right, in terms of spiritual, depending on your denominations, right? How do you identify yourself? But I feel that also, and there's a lot of research on that as well, in which also there's this community aspect, but also there's a spiritual aspect in whatever you want to believe. That also is part of the whole wellness, right? So I feel that making a change in your lifestyle in general can make bigger changes, not only for avoiding, right, further health issues, but also mental issues as well. I feel that we don't talk about it that often, but I feel it's as important to talk about mental health, right, than also physical health. And I feel everything is connected. So I feel that for sure, making modifications to your lifestyle can also decrease the risk for further down the line acquiring these diseases.
Thank you for that. We also, I'm going to go back to a couple of the questions that were submitted at registration. And we had a couple questions related to health disparities, which you've covered so beautifully in the presentation. But one specifically asked about locating clinicians sensitive to those health disparities and what recommendations you have for that.
Yeah, for sure. I feel community partners are very essential in this sense. I feel they will be able to help you, guide you to the whole process. We know that there's some bureaucracy, right, associated with how we access, right, to healthcare. But I feel once you find that community partner that can help you identify the clinician that is sensitive, right, to issues of health disparities. Also, another aspect is to verify if the physician and the clinician has experience, right, with Hispanic groups, with natives, with African Americans. There are different ways in which you can actually know about that information. But I feel maybe doing a little bit more research on the clinician, what the person has been doing, what is their involvement with different communities, because that way I feel the clinician may have a more culturally relevant aspect to it as well. So I feel community partners for sure, and then doing the research to see if that clinician for sure had experience with issues of health disparities, but also treating patients from these communities as well.
Could you talk a little bit more about community partners? Who would you consider to be a community partner?
Yeah, community partner can be a leader in your community. It can be a leader of your church. It can be a leader in your school if you're in the school. Also, I know the government, they provide different community partners that can help you access to different specific information regarding access specifically to healthcare. So I feel those are the main ones. I know different entities also have different specific groups. So for sure, that will be the resources they can reach out.
Wonderful. Well, thank you so much, Dr. Ortiz. We're nearing the end of our time together, and I wonder if you could. We'll look at the cancer support community slide. I was going to have you go back, but I think it's this will be great. We really would like to thank you for your time.
Thank you for having me
today, for your expertise, and I want to thank our attendees for engaging with us and for their participation as well. I also wanted to make mention of what is in the chat. We have Crystal Morse, who is with us today, who is with Physician Relations at City of Hope and has put her information in the chat as well. So if you have any questions for her, and Crystal, maybe you want to just give a quick hello and so people can put a face to the name.
Hi, everyone. My name is Crystal Morse. Thank you for having us today. I work in the Physician Relations Liaison Department. So if you guys have any questions in regards to our services or specialist, I put my information in a chat box. Please reach out. Or if you belong to an organization in the community that is looking for education, we are here and we are able to connect with our community. Thank you so much. And thank you so much, Kathy, for having us.
Yeah, you're very welcome. And also, if you would like to learn more about the cancer support community in Los Angeles, you can see on this slide that we've got our website listed. And also, if you would like to receive a copy of today's slides, you can email us at info@cancersupportla.org. Again, that is info@cancersupportla.org. And we would be, Dr. Ortiz has graciously offered to share those slides, and you can see that email has been put in the chat. So, well, this concludes our webinar. What a wonderful presentation and great conversation. Thank you, Dr. Ortiz, and we'll see all of you at a future webinar. Thank you.